You know, usually when we think of a failing heart, we picture this like engine that has simply worn down over decades.
Right.
There's this cultural expectation that heart failure is just the end of a very long, very predictable road of cumulative wear and tear.
Oh, absolutely. It's the classic 80-year-old machine that has finally just run its course.
Yeah.
That's the clinical scenario most people, and honestly, like many medical students, are conditioned to expect.
But imagine you encounter a scenario that completely shatters that expectation.
Hmm.
You are looking at a 22-year-old athlete. They are perfectly healthy. They have a pristine diet. They run marathons. And suddenly their heart just stops functioning.
Huh.
The engine doesn't wear down over time. It essentially, tears itself apart from the inside out in a matter of days.
It is arguably one of the most terrifying medical mysteries we encounter.
Yeah.
I mean, it strikes people who are otherwise in the absolute prime of their lives. And, it masquerades as other much more common diseases, making it incredibly difficult to catch before it's too late.
Which is exactly why you need to know about this. Welcome to the Deep Dive. Today, we're looking at what happens when the body's ultimate engine goes rogue.
Exactly.
We're using Dr. Asifula's clinical practice guidelines, specifically the USMLE Step 2 notes, to investigate this medical chameleon known as myocarditis. Our mission today is to unpack the mechanics of this condition, figure out how doctors actually hunt it down, and understand the extreme measures used to stop it.
It's a fascinating journey.
Okay, let's unpack this. What exactly happens when the body's own defense system decides to turn against its most vital organ? Because to understand how clinical teams fix this, we first need to understand how the heart gets broken in the first place.
Right. So we have to start at the microscopic level.
Okay.
At its core, myocarditis is simply inflammation of the myocardium. That's the thick muscular wall of the heart.
Got it.
But that inflammation leads directly to myocyte injury. And when those myocytes, the actual muscle cells that contract to pump your blood, are injured and start dying, it triggers a catastrophic domino effect.
Like what?
Well, the electrical pathways get disrupted, causing dangerous arrhythmias.
Oh, wow.
The mechanical pump fails, which leads to heart failure. And in the most severe cases, it culminates in sudden cardiac death.
And looking at the clinical data, the trigger for this massive cascade is often surprisingly mundane.
Very much so.
There's this overarching clinical mnemonic used for the causes in the notes. It's viral heart.
Yes.
And viruses are absolutely the most common culprits here. We're talking about things like Coxsackie B, adenovirus, parvovirus B19, SARS-CoV-2, and even standard influenza.
What's fascinating here is that a completely routine pathogen, something that usually just gives you a minor fever, some body aches, and a cough can, in rare cases, become the catalyst for total cardiac collapse.
It's crazy to think about.
It is, but those triggers extend far beyond common viruses. If you look further into the data, you find immune conditions like sarcoidosis or giant cell myocarditis.
Right.
You also see rare hypersensitivity reactions, particularly to immune checkpoint inhibitors.
Oh, let's pause on those checkpoint inhibitors for a second, because that feels like a really crucial modern medical context.
Those are cancer drugs, right?
Yes, exactly. They are essentially modern miracles for oncology.
Yeah.
They work by taking the brakes off the patient's immune system so it can aggressively hunt down and destroy tumors.
Makes sense.
But without those regulatory brakes, the immune system can sometimes lose its target identification and decide to attack the healthy myocardium instead.
Okay, that makes a lot of sense. The system is just hypercharged and starts firing at everything.
Precisely.
And the clinical list also includes atypical infections like Lyme disease and toxic exposures to drugs like cocaine or extreme alcohol abuse. So the triggers are really everywhere.
They are?
But here's what I really want to understand about the mechanism. If a standard flu virus is the trigger, is the virus itself literally chewing through the heart muscle? Or is this basically like a mechanic trying to fix a tiny scratch on an engine block, but they end up smashing the pistons with a sledgehammer? That sledgehammer analogy captures the pathophysiology cascade perfectly.
Really?
Yeah. The virus or the toxin is just the initial intruder. It might cause a tiny bit of direct damage, but mostly it just sets off the alarm bells.
Ah, okay. Wait, so the virus itself isn't necessarily what destroys the heart tissue, it's our own immune system overreacting to it.
Exactly. This leads to massive immune activation and a flood of inflammation. That inflammatory response is the sledgehammer.
Wow.
Your body's hyperactive immune cells, like T cells and macrophages, they flood the cardiac tissue to attack the infection. But they release toxic cytokines that cause myocyte necrosis, which is widespread cell death, just right in the crossfire.
So it's basically friendly fire on a catastrophic scale.
That is the exact mechanism. And when those muscle cells die, their membranes rupture, spilling their internal contents.
Which probably makes things worse.
Oh, it does. It only triggers more inflammation. It's a vicious cycle. That necrosis leads directly to left ventricular dysfunction. As the healthy muscle dies, it gets replaced by flimsy scar tissue. The heart structure actually stretches out and balloons, leading to dilated cardiomyopathy.
Jeez.
The heart becomes this weak, flabby sac that simply cannot push blood forward.
Okay, so if this microscopic internal battle is raging, what does it actually look like from the outside?
Right.
Like, imagine you're an ER doctor. A young patient walks in. What are the clinical red flags you're looking for before the heart balloons into a flabby sac?
Well, you're initially looking for a classic triad of symptoms.
Okay, what are they?
First, a viral prodrome. This means the patient will usually tell you they felt sick a week or two beforehand.
Like if they had a cold.
Exactly. Maybe a mild fever or respiratory symptoms they thought they'd already shaken off.
Got it.
Second, they present with sharp, sudden chest pain. And third, they have dyspnea, which is severe shortness of breath.
Wait, if a patient comes into the emergency room clutching their chest and struggling to breathe, the entire clinical team is immediately going to scream, heart attack.
Oh, 100%.
So how do doctors avoid getting tunnel vision and treating it like a standard heart attack when the presentation is almost exactly the same?
That is the ultimate diagnostic trap. Myocarditis is a complete chameleon.
Yeah.
Beyond that classic triad, you might see palpitations or syncope, where the patient just faints out of nowhere because their blood pressure plummeted.
Very.
And if you listen to their chest with a stethoscope, you might hear a racing tachycardia or a very specific sound called an S3 gallop.
An S3 gallop. What does that actually mean mechanically?
Normally, a healthy heart makes a crisp lub-dub sound as the valve snaps shut.
Right.
The S3 adds a third low-frequency sound, giving it the cadence of a galloping horse.
Oh, interesting.
Mechanically, you are actually hearing the sound of blood aggressively sloshing into a dilated, non-compliant, failing left ventricle.
Wow.
You might also find pulmonary edema. Because that left ventricle isn't pumping blood forward effectively, the blood backs up into the left atrium and then further back into the pulmonary veins.
So it pushes into the lungs.
Exactly. It pushes fluid directly into the air sacs of the lungs. That's why the patient is experiencing that profound shortness of breath. They're essentially drowning in their own backed up fluid.
And the clinical guidelines outline absolute red flags for immediate admission, right?
Yes, they do.
We're talking about sustained ventricular tachycardia or ventricular fibrillation lethal rhythms where the heart is just quivering.
Right.
A high-grade AV block, meaning the electrical signals telling the chambers to pump are completely failing. Or cardiogenic shock, where the pump function is so profoundly depressed the patient's organs are shutting down right in front of you.
Those are the extremes, yes.
Yeah.
But getting back to your question about avoiding the heart attack tunnel vision.
Yeah.
The guidelines highlight a specific high-yield pearl for differentiating the two. It revolves around a protein called troponin.
Okay.
Troponin is part of the structural scaffolding inside heart muscle cells. It only leaks into the bloodstream when those cells are physically dying.
So in a standard heart attack, a blocked coronary artery starves the muscle of oxygen, the tissue dies, and the troponin spikes.
Exactly.
But in our young patient with myocarditis, their immune system's sledgehammer is destroying the cells, which also causes the troponin to leak out.
You've hit on the core diagnostic dilemma right there.
Yeah.
The blood test screams heart attack.
Right.
So the ER team rushes this young patient to the catheterization lab to fix the plumbing. They inject the contrast dye, expect to find a massive blood clot blocking a coronary artery. And the imaging shows arteries that are completely 100% normal.
Wide open.
Wide open.
That is wild.
It is. That specific combination, a young patient, sudden chest pain, highly elevated troponin, but perfectly clean coronary arteries, is the giant flashing neon sign for myocarditis.
Oh.
The cardiac tissue is dying, but it's not a plumbing problem. It's an inflammatory one.
Here's where it gets really interesting. You know it's not a blocked pipe, but you still need to definitively prove it's myocarditis because the initial workup described in the guidelines seems pretty broad. You have the elevated troponin, maybe an elevated BNP, which indicates the heart is under severe stretch and skyrocketing inflammatory markers like CRP. The ECG shows wild, non-specific changes that can easily mimic a heart attack or pericarditis. Even an echocardiogram might just show global hypokinesia, meaning the whole heart muscle looks universally sluggish. It doesn't give you a definitive answer.
Which is precisely why the clinical pathway relies so heavily on advanced imaging. Cardiac MRI is considered the absolute best non-invasive test we have for this.
Okay.
We evaluate the images using something called the Lake-Louise criteria. Yeah. We are looking for 3 specific tissue markers: edema, active inflammation, and necrosis or fibrosis.
Right.
And to visualize that scarring and necrosis, we use an inert metal contrast agent called gadolinium.
Let me guess, this is the late gadolinium enhancement, or LGE, mentioned in the notes.
Yes, exactly.
How does a metal dye actually show us a viral immune war zone?
Well, in healthy, tightly packed heart muscle, the gadolinium washes in with the blood and washes right out.
Okay.
But when there is severe inflammation, the spaces between the cells physically expand.
Right.
And when there is necrosis, the body lays down dense networks of collagen to form a scar.
Oh, I see.
So the gadolinium molecules get physically trapped in those expanded spaces and scarred areas.
Got it.
If we take the MRI picture late in the scan, hence late gadolinium enhancement, the normal tissue is dark, but the damaged scarred areas glow bright white.
And the actual pattern of that glowing white enhancement is the real detective work here.
Yes.
The guidelines point out that in a heart attack, the damage is subendocardial or transmural, meaning it starts on the inner lining of the heart wall.
Exactly.
But in myocarditis, the damage is strictly mid-wall or epicardial, the middle or the outside. I'll see if I can logic this out. If an artery on the outside of the heart gets blocked by a clot, the tissue furthest away from the blood supply, the inner lining, starves and dies first.
Spot on.
But myocarditis is a systemic inflammatory attack. It's attacking the tissue directly via the microscopic vessels, which somehow spares the inner lining and hits the middle of the wall.
That deduction lines up perfectly with the clinical anatomy. The inflammatory cascade of myocarditis uniquely targets that middle myocardium and the outer epicardium, entirely sparing the subendocardium.
Wow.
So if your MRI shows a bright white stripe of scarring right down the middle of the heart wall, you've officially caught your chameleon.
That's incredible. But then we have the endomyocardial biopsy.
Yes.
The guidelines label the biopsy as the absolute gold standard for diagnosis. If it's the true gold standard, why isn't it the very first thing we do? Like, why wouldn't we just biopsy everyone to be 100% sure right off the bat?
If we connect this to the bigger picture, it comes down to a strict risk versus reward calculation.
Okay.
An endomyocardial biopsy is highly invasive. You are threading a catheter through the vascular system into the right ventricle and using tiny jaws to physically snip away microscopic pieces of the beating heart muscle. Right. And the right ventricle has a relatively thin wall, so that there is a very real risk of perforating the heart or inducing a lethal arrhythmia. You only take that immense risk if the result of the biopsy is going to radically change your management strategy.
Ah, I see. So if the MRI already confirms standard viral myocarditis, snipping a piece of the heart won't change anything.
Exactly.
You're just going to medically support the patient while their immune system calms down and the tissue heals anyway.
Yes. You only proceed to a biopsy if the patient is in unexplained, fulminant heart failure or cardiogenic shock, and you suspect a highly aggressive, specific variant like giant cell myocarditis or eosinophilic myocarditis.
Because the treatment is different.
Very different. If a biopsy confirms giant cell, supportive care is absolutely not enough. You have to immediately deploy massive doses of targeted immunosuppressants to stop the immune system. Otherwise, the patient will rapidly progress to death or require an urgent heart transplant.
Which brings us perfectly into the management phase. The diagnosis is confirmed, the patient is admitted. How do we actually fix the broken pump?
Right.
Because the guidelines establish a very specific playbook for heart failure. If the ejection fraction, which is the percentage of blood squeezed out with each beat, is reduced, we're looking at administering ACE inhibitors, ARBs, RNIs, MRAs, and SGLT2 inhibitors.
We use these agents to fundamentally alter the neurohormonal environment of the failing heart.
How so?
Well, when the heart fails, the body panics. It releases hormones that clamp down the blood vessels to keep blood pressure up.
Right.
But that vasoconstriction forces the already weakened heart to push against immense resistance. Medications like ACE inhibitors relax those vessels, unloading the workload on the heart.
Okay.
Meanwhile, SGLT2 inhibitors, which actually started as diabetes drugs, significantly alter myocardial metabolism and reduce filling pressures in ways that drastically improve survival.
But there is a massive clinical caveat here regarding beta blockers. The guidelines state you only start beta blockers after the patient is clinically stabilized.
Yes.
Normally, beta blockers are a foundational pillar of heart failure treatment. Why the delay?
Beta blockers possess inherent negative inotropic effects.
Meaning?
That means they fundamentally reduce the mechanical force of the heart muscle's contraction.
Oh.
In the acute unstable phase of myocarditis, the heart is already barely squeezing hard enough to keep the brain and organs perfused.
So if you slow it down...
If you introduce a beta blocker too early, you strip away whatever vital compensatory contractility the heart has left. You could inadvertently push the patient straight off a cliff into cardiogenic shock.
Speaking of falling off the cliff, what happens in fulminant myocarditis? Like, the patient is crashing, the pump is essentially giving up.
That requires immediate escalation to the intensive care unit. We move to powerful intravenous inotropes and vasopressors to artificially stimulate contractility and clamp the blood vessels.
Okay.
But if pharmacological support fails, we have to rely on mechanical circulatory support, devices like an intra-aortic balloon pump, an Impella, or VA ECMO.
Let's unpack the mechanics of VA ECMO and Impella for a second. How do those machines actually buy the heart time to heal?
An Impella is a miniature continuous flow pump inserted via a catheter directly into the left ventricle.
Right.
It acts like an artificial propeller, constantly pulling blood out of the ventricle and injecting it into the aorta, mechanically doing the work the muscle can no longer do.
That is amazing.
It is. And VA ECMO, which stands for veno-arterial extracorporeal membrane oxygenation, is even more extreme.
Oh.
We essentially route the patient's deoxygenated blood entirely out of their body, run it through an artificial lung machine to oxygenate it, and pump it back into their arterial system with continuous force.
Wow.
It completely bypasses the heart and lungs, allowing the inflamed myocardium to rest in total hibernation.
We literally bypass the engine so it can cool off.
Exactly.
Now, as I was reviewing this management section, some of the most fascinating clinical points were the strict do nots. These are interventions you'd logically assume would help, but are explicitly forbidden. First up, do not routinely use NSAIDs. If myocarditis is fundamentally an inflammatory disease, why on earth are we avoiding standard anti-inflammatories like ibuprofen?
It feels entirely counterintuitive, doesn't it?
Yeah, completely.
But NSAIDs work by inhibiting prostaglandins to reduce inflammation. The problem is, while prostaglandins drive the inflammatory response, they are also absolutely critical for the complex tissue repair phase.
Interesting.
When the myocardium is necrotic, it needs fibroblasts to lay down a stable collagen network to patch the holes and maintain the structural integrity of the ventricular wall.
So they need the prostaglandins for that.
Right. By blanketing the system with NSAIDs, you block those prostaglandins and interfere with that early healing phase. It's akin to firing your construction crew right after an earthquake. You increase the risk of adverse remodeling and permanent damage.
That makes a lot of sense. The second major DO not is no routine antiviral therapy, even if we have definitively proven a virus caused the whole cascade.
By the time the patient presents with severe heart failure, the initial viral replication phase is usually long over.
So the virus is gone.
The virus has left the building. What you're treating now is the immune system's hyperactive aftermath.
Right.
Giving antivirals at this stage is like spraying a fire extinguisher at the arsonist's car while the house is already engulfed in flames.
That's a great way to put it.
You only use targeted antimicrobials if the trigger is a chronic ongoing infection like Lyme disease or Chagas disease.
And the third surprising rule, do not implant a permanent ICD, an implantable defibrillator during the acute phase.
Right.
These patients are at incredibly high risk for lethal arrhythmias. It seems like you'd want a shock device in there immediately to prevent sudden cardiac death.
You certainly monitor them continuously on telemetry,
Well.
and you might use a temporary wearable defibrillator vest.
Okay.
But you don't permanently implant hardware in the acute phase because viral myocarditis is fundamentally reversible.
Oh, I see.
The heart muscle can fully recover. You wait, support them medically, and reassess their ejection fraction after 3 to 6 months. You only implant a permanent ICD if their pump function fails to recover after that window.
That timeline brings up a huge lifestyle impact.
It does.
The guidelines put an absolute restriction on competitive sports or strenuous exercise for 3 to 6 months. So telling a highly active 20-year-old athlete they can't elevate their heart rate for half a year is devastating. Is the myocardium really that fragile during this healing window?
It is incredibly vulnerable. When the myocardium is actively inflamed and trying to lay down stable scar tissue, asking it to dramatically increase its cardiac output through strenuous exercise creates the perfect electrical and mechanical storm.
Wow.
The increased sympathetic drive and sheer physical stress can easily trigger those lethal ventricular arrhythmias. To return to play safely, they must meet strict criteria.
Like what?
Their ejection fraction must normalize, troponin levels must drop back to 0, a Holter monitor must show no significant arrhythmias, and they need a full clinical recovery.
So you really can't rush it.
Pushing it too soon isn't just risky, it actively invites sudden cardiac death.
And force rest to let the engine rebuild.
Exactly.
If we look at Dr. Asifula's overarching myocarditis mnemonic, it really synthesizes the entire clinical journey we've mapped out today.
It's a very helpful summary.
You have a young patient with an elevated troponin. You rule out a standard heart attack, use an MRI to spot that mid-wall damage, observe them closely for lethal arrhythmias or cardiogenic shock, and ultimately, you stop sports for 3 to 6 months to prevent the progression into dilated cardiomyopathy.
This raises an important question, though.
Uh-huh.
Something really worth pondering as we step back from the acute clinical data.
Okay.
If mild viral myocarditis can sometimes go completely unnoticed, masquerading as just a bad case of the flu with a little chest tightness that you push through and ignore,
Yeah.
what happens decades later?
Wait.
The mnemonic highlights dilated cardiomyopathy as the feared long-term complication.
Yeah.
Could some of the cases of unexplained chronic heart failure we see in older adults actually be the ghost of a mild, undiagnosed viral infection they had in their 20s?
Oh my God.
A scenario where their immune system silently damaged a microscopic portion of the heart, and it just took 40 years for that weakened engine to finally give out.
That is a haunting thought. It completely reframes how we think about the common cold and the hidden microscopic battles our immune system fights beneath the